interactions now. Column 1 still represent pro-social preferences, whether measured as stated altruism or hypothetical dictator game. Column 2 and 3 represent providers' willingness to offer self-injection to either of this profile. And so assessing column 1 and column 3, we see that altruism was not correlated with providers' willingness to offer DMPA-SC to older married women. But then, assessing column 1 and column 2 in row 2, we see there was a positive correlation between altruism and providers' willingness to offer DMPA-SC to young unmarried women. And what this simply means is that the more altruistic the provider, the more willing they were to offer DMPA-SC to this profile, hence the positive correlation. What does all this mean? So we've seen that using provider IDIs, triangulating it with mystery client visits, we've seen evidence of both provider bias and pro-social preference or pro-sociality among providers of DMPA-SC in Lagos, Nigeria. We've seen that from the IDIs, providers stated less willingness to offer DMPA-SC to young unmarried women compared to older married women. But then this gap shrinks when comparing their actual behavior from the mystery client visit. And so these discrepancies reinforce the need to triangulate data across sources. We've seen substantial evidence of altruism amongst providers, where we see altruism positively correlated with providers' actual willingness to offer DMPA-SC for self-injection to young unmarried women. And so what these particular findings suggest that providers' pro-social preference or altruism may be offsetting any inherent bias they might have towards young unmarried women. So in conclusion, our findings open up a range of opportunities for policymakers who can harness providers' underlying pro-social preference and tailor interventions to help increase contraceptive access, including DMPA-SC for SI, especially for young unmarried women. And on that note, ladies and gentlemen, I've come to the end of my presentation. I want to use this opportunity to thank our sponsors and other implementing partners for their support with us on the ICANN project. Thank you.
Okay, thank you very much for the presentation about biases of self-injection in Nigeria. Our third speaker is a senior technical advisor, researcher, and learning at PSI. She works on the ICFP fund delivery innovation in self-care implemented in Uganda, Nigeria, and Malawi. She has more than 10 years of experience implementing family planning projects in several countries of sub-Saharan Africa, and she's currently a member of FP 2030 implementing group. Ladies and gentlemen, please welcome Dr. Susan Ontiri.
Good morning, everyone. This morning, I'll take you through our presentation on a study we did on missed opportunities for self-injection service provision. This was basically done as one of the baseline studies that we did to inform our programming in Uganda and Nigeria. I won't go much into the benefits of self-injection because Dr. Costas in his opening remarks already outlined the importance of this new method, the fact that from the studies that have already been published, we basically see self-inject as a new method that can expand the contraceptive options for women. It basically gives, autonomy and agency to women. But one of the things that has also been reported is the fact that when you compare with, for instance, the provider-administered method, there is higher continuation rate among women who actually take self-injection. So the project Delivering Innovation in Self-Care is a Children Investment Fund Foundation project, a 5-year grant that is in Uganda and Nigeria, and now moving into Malawi with Bill and Melinda Gates Foundation. And it basically aims at increasing awareness and scale up of self-injection among women. At the onset of the project, that was mid last year, we sought out to find out some sort of a baseline assessment. What is the current extent of SI information in Uganda and Nigeria, and to basically understand the care cascade of this method among women who are seeking family planning. Because as we all know, women cannot choose a method that they are not aware of. And at this juncture, let me ask, who knows the current awareness of self-injection? By show of hands, a quick. Yeah. Yes? Yes. Awareness level, at population level. Who knows? Just guess. Any. That's part of also the answer. 11%. So that's actually one of the knowledge gaps. We don't know the level of awareness globally, but when you look at the recent published performance monitoring action that was done in Nigeria, Democratic Republic of Congo, Kenya, and Burkina Faso, it actually showed us that the level of awareness ranges from 13% to 24%, which basically shows there's a lot of work to still be done. So in this particular study, we decided to do something that we rarely see in family planning. I know care cascade is mostly presented in the HIV sector, but in family planning, we wanted to find out among the women who have basically received a method, and this is any contraceptive method, how many were informed by a provider about self-injection prior to the visit to the facility and prior to taking up a method, knowing very well that women are an important and trusted source of SI information, and not just SI, but contraceptive in general. And out of those who were interested in learning more about SI, how many were actually informed by the provider during that contact? Of those who were informed, how many were trained on SI? And from those who were trained, how many ended up adapting SI? This was a mixed method sequential explanatory study where we basically looked at over 1,200 family planning clients who visited 6 public health facilities, 3 in Nigeria and 3 in Uganda. From out of the 1,200 women, we basically analyzed 930 women who expressed an interest in SI. And from those, following that analysis, which was quantitative in nature, we did interviews with 26 DMPSC providers from both countries to basically understand their perspectives on SI service provision. Thereafter, we were able to triangulate the quantitative and qualitative information to gather additional insights on whether there are any convergence or divergence. So what did we find out? When you look at Uganda, of our total sample of 492, this is a cascade. The first 6, okay, it's not working. The first 6 bars are basically, these are just absolute numbers. The same women from 492, which was a sample, 430 women expressed an interest in learning more about SI. These 430 women were women who ended up taking up a method, any method ranging from the lax and also the shorter method. Out of the 430 women, which represented almost 9 out of 10 women, 66% of the women, the 288, indicated that they were interested in learning more about SI. And when you see this graph, you can see the figures reducing. But out of the women who were interested, only 60% were offered to be trained, meaning there are 40% of the women who would have expressed an interest, but they were never given that opportunity to be trained. From those who were trained, 60% of those who were trained adapted SI, and out of those who adapted SI, only 45% were allowed to take the DMPSC doses home. And these were women who were eligible to basically take DMPSC doses home. When you look at Nigeria, our initial sample size was 720 women. Only barely 7 out of 10 women expressed an interest in learning more about SI. We are seeing this number almost reducing to 60% who indicated of those who indicated they were interested were actually informed about it by a provider. And of those who were trained of SI, only 23% ended up adapting, meaning around 70% took up other methods or took up provider-administered method. And from those who are eligible, again, noting that Nigeria, depending on the facility context, women may not be allowed to take up extra doses home during their first visit. It's only allowed during their subsequent visit. Only 5% took up the additional doses. When we looked at the predictors of who were likely to be informed of SI, one thing we learned was that depending on the type of user, women who are switching from one method were 5 times more likely to be informed of SI in Nigeria and 2 times more likely to be informed of SI in Uganda compared to those who are coming, for the same method. Again, in Nigeria, new users or new contraceptive women, users who are basically adapting SI, were 4 times more likely to be informed compared to those who are again coming for revisit. In both countries, there are no significant differences when you look at the socio-demographic characteristics such as age, marital status, education level, or fertility intention. What did we explore in our interviews with the provider? One, SI counseling practices. One of the things we learned was the counseling practices varies depending on the type of users. And one provider mentioned those who come to take, who are coming to take the previous method, we just provide that method. We basically don't again start, counseling or providing them information. Is this a problem? I'll leave you to ponder it. But remember, in as much as I come to a facility to take up, let's say I'm still using an implant, I'm still surrounded by other women. I can still be a trusted source of information, considering that SI is a new method. So our hope is that all women who have at least that contact with a provider should basically know about this additional method. They may opt to use, they may opt to switch, but at least they will be able to have that information that they can pass to other women, that there is this new additional method that is available to them. When we specifically looked at the DMPA IM clients, we also realized that SI information is not provided consistently to all women, depending again on the caseload and, providers' preferences. When we looked at SI training, one thing that came up is the workload. Providers mentioned that SI training takes a lot of time. So training will only happen when there are no, major queues in the facilities or long queues, or when they are busy, they don't like offering SI because it really takes time. And when you see, like in Nigeria, SI conversion after being trained is only 20%. So providers will most likely just prefer to provide the provider administered. One thing we also noted was provider barriers. And as has been mentioned in the other presenters, adolescents and youths were not most likely to be trained on SI, depending on the provider preferences. The other thing that also came out was the whole aspect of the provider capacity. I mentioned that we did this at the inception of the project. And most providers say the training that received was on DMPSC provider administered. They're not being trained on how to train women on how to self-inject. When it comes to SI adoption, 2 main things, lack of confidence and fear of needles. Again, that prevented women from actually, after even undertaking the training, that fear of the needle prevented them from adapting SI. Like one provider in Nigeria mentioned, I took time and trained this woman so well, she held the skin, but she pleaded with me to actually complete the process. We also tried to find out why is it that women are not being given additional doses to take home. 3 things came up. Stockouts. They don't give women doses if there is a shortage of stockouts. And even if there is, sometimes if they have adequate stockouts, they'll still maybe prefer to give a woman 1 dose only and not allow them to get 2 or 3 doses as per what is in the guideline. Again, the issue of the guideline mentions that doses should only be given to women who are comfortable to basically take up SI, meaning the provider is at her own discretion to decide whether this woman, based on what she's observed, she's basically capable of taking or doing self-injection at home. But there was also other client level facilitators that privacy. Some women who basically came to the facility to self-inject say they didn't want to take the doses home because they were covert contraceptive users. So what are some of the learnings from these? One, more than a third of women interested in learning about SI, they basically, more than a third of women are interested in learning about SI. They basically leave the facility without receiving SI information. Like in Nigeria, only 50% of DMPA IM women, because we asked that question of, are you aware of a self-injection that can, a contraceptive method that you can inject? And out of our sample of 492 women, only 50% were aware of SI. And remember, these are family planning clients. In Uganda, it was actually 60%, which again shows missed opportunity, the fact that we are not basically fully maximizing the client-provider interaction that we have. Again, only a third of women trained in Uganda and 1 out of 10 in Nigeria end up adapting SI. This may not be a bad thing because, again, remember in family planning, we talk about trust-based approach. It could also be a depiction of informed consent. It's not a must that after you train a woman, they end up taking a method. SI clients not receiving additional doses, basically negating the potential gains that are made to when we scale up this method. Again, one of the things that came out, and we've also heard, is the fact that providers seem to act as gatekeepers on the type of information they want to give. Based on the profile of the women, they may decide to train you or not train you, inform you or not inform you on SI. So what did we do following these findings? We basically did some sort of adaptive implementation of our DISC project. And when we looked at the DMPAC curriculum, we realized that whereas the curriculum was very strong in providing, or rather impacting knowledge on provider administered on SI, there was the whole component of empathy. We keep on hearing that women have this fear and lack confidence of, self-injecting. So we developed a module on how to basically deliver a self-injection through an empathy module, and this basically focused on building the capacity of providers to coach women on how to allay their fears on self-injection. And one of the things that we are doing is providing training on women and also ensuring that there is demand generation, there's commodity security, supportive supervision, and basically improving the provider's capacity on reporting. And when I'd like to show you one of the graphs that we have on our routine data, this is basically SI uptake. I mentioned within this study last year at around Q3, Q2, Q3, and at that point, only 16% of DMPAC clients were taking up SI. And when you look at this graph, you can basically see even that SI visits were very low. The yellow bar is Uganda and the green bar is Nigeria. When we integrated the moment of truth training, you can clearly see there's been consistent increase in not only the SI visits number in those facilities, but also the proportion of women who end up adapting SI following a training. If you want to know more about DISC, you can use your scan and get access to this, but we also have a number of presentations in other forums that, again, go into details about the moment of truth training and what we've seen. Thank you.
Thank you very much for talking to us about the opportunities and the gap that exists in about the safe injection program. Our last but not least speaker is the senior lecturer at the Kamuzu University of Health Science. She is the head of the Department of the Midwifery and the School of Maternal, Neonatal, and Reproductive Health Studies. And she presents the ICANN Malawi MAST team in the DMPASK project. Ladies and gentlemen, let's welcome Dr. Marita Kamanga.
Thank you. Good morning. Okay. I'm Dr. Martha Kamanga, representing the ICANN Malawi, and I'll be presenting on how can self-injection promote contraceptive agency. And this is a qualitative study of the potential of self-injection from the perspectives of women in Kenya, Malawi, Nigeria, and Uganda. So those are the countries I'm representing: Akina Plus, Nigeria; Makerere University, Uganda; Kenya Medical Research Institute, Kenya; Malawi University of Science and Technology, Malawi; and University of California, San Francisco, United States. So as a project ICANN, we have two guiding questions. The first one is, how can self-injection of subcutaneous DMPSC be implemented in a way that best meets women's needs as they themselves define them? That is our first question. And also as ICANN, we have a second question. Can self-injection enhance contraceptive agency for women who face the most barriers? So my presentation will focus on the second question. First, to understand what is contraceptive agency, ICANN is developing and validating a new scale to measure this two-domain construct to serve as a new outcome measure for the family planning field. So we have the agency in decision-making. We want women to have the ability to make decisions, and then agency in acting on decisions. Women should not just make decisions, but they should also have the ability to act on the decisions that they make. So, as ICANN, what we identified is self-injection is a promising self-care intervention shown to be safe, feasible, and acceptable. However, we noticed that the rates of uptake and interest have been low so far globally, including in the countries that we are representing. And little is known about the perspectives of self-injection among those not already using it. Why is it that they are not using it, even if it is promising? So we had these questions. How can self-injection promote contraceptive agency from the perspectives of potential users? That is from our second question. Yeah, we wanted to understand what benefits do women articulate and what barriers to agency would SI help overcome. And also we had a question on what are the contextual factors that influence women's ability to benefit from SI's value in the countries I mentioned. And we conducted in-depth interviews with women in Kenya, Malawi, Nigeria, and Uganda through community-based recruitment in 2 different geographical sites per country. And data collection was from January to September 2021. Purposive sampling by age and contraceptive use. And then interviews explored contraceptive decision-making, contraceptive use, interest in using contraceptives, and perspectives on self-injection. And data coded by 5 country team members, and also modified grounded theory approach to thematic analysis was used. Our results on the demographic characteristics, we categorized our participants by contraceptive use, and then that's non-users versus prior use. And then also by age, they were like in 2 age categories. That's 15 to 19 and then 20 to 19. So if you look at the column for non-use, we have the 15 to 19 category for Kenya, Malawi, Nigeria, and Uganda, totaling to 43. And also we have the age category 20 to 45 on the non-users, totaling to 47 for the 4 countries. And then on the right side, we have prior use for contraceptive, where we also have those categories 15 to 19 and 20 to 45. And 15 to 19 totals 45, 20 to 45 totals 105, and our total sample was 241 for the 4 countries. Coming to our findings, they highlight 3 important aspects. That's the potential for self-injection to offer privacy, the potential to ease access of barriers, and the potential to give a sense of control to the user. Firstly, on the privacy issue, I know it has already been tackled by the previous presenters. So we had privacy like in 3 areas. That's privacy within the home. Like we have a 30-year-old user from Uganda who is saying some men are not supportive and understanding. If you have the injection at home, you just go ahead and use it anytime, and he wants to know. So these are the private users within the home where they have problems with their partners. And also privacy from the community. So we have one participant, 25-year-old from Nigeria, who is saying, privacy, I feel safe now because nobody knows what I do, since I do it in the comfort of my house. So the community is not aware of what this woman is doing. So she's comfortable with that and she's okay. And also there was privacy like partners appreciate the privacy too. So as a partner, they don't want many people to know that their wife is using the self-injection. So it was okay for them. And you look at the age of this one, is 17-year-old non-user from Uganda. And on our second highlight, we say women are impressed with self-injection potential to ease access barriers to contraception. And we had those quotes from Nigeria, Kenya, Malawi, and Uganda. So, for example, they are referring to no more time wasting. Also, you rely on your own supply. You don't have to keep going to the healthy facility if you don't have supply, because you have supply for almost a year. So that was good for a Malawian young lady, 16-year-old. And also on time wasting, there was a quote from Nigeria, 44-year-old condom user, who said the benefit is that time it will take me to go to the hospital. I will inject myself at home and go to where I want to go. Because if you go to the hospital, you might meet crowd. Then you may spend a whole day just to take an injection. So they don't want to waste time. They have other things to do. And also it's cost saving. We know of the transport issues. That's a user, 35-year-old user from Kenya. And also avoiding bias and endless questions. Sometimes providers, they ask too much questions. So you look at this 17-year-old oral contraceptive user from Kenya who is avoiding these questions. To them, it's like maybe we are bothering them. So they don't want to go to the clinic. Better they have the SI and inject themselves. And then on the third aspect, on the third highlight of sense of control, we also have those quotes like embracing control. That I felt so good. The day that I injected myself at the hospital, I also felt good the second time that I was injecting myself because I followed that. And I followed what they had told me. This is a 33-year-old user from Malawi. And somebody also felt in control that they are taking control or they are taking care of their own body. And this is a user from Uganda, 19-year-old, who is feeling in control. You can tell the health worker that it is paining and she does not care. But here you inject yourself with sympathy for your body. So it's like, as providers, maybe we lack feelings for them, but as they are injecting themselves, they are in control and they feel good about it. And also trusting in yourself. It is beneficial because it is me who injects myself. You yourself will be sure you will not miss your days. So they are feeling in control, which is good. So who are these women who are benefiting from SI? We have the adolescents, we have women who fear interactions with the health workers, and we have women with disapproving partners. These are really benefiting from the SI, and they will promote its use. I'll just give one quote from Nigeria where they're saying, I wouldn't like to keep it at home because it might get me into trouble with my parents. This is a 19-year-old non-user of contraception in Nigeria. And the issue of fears keep on coming in almost all the presentations. So it's say, fear of mismanaging the injection are common. Fears of lack of support are common. Fears of injection pain, almost everywhere. I feared, I was shaking, I did this. It's painful. But the fears can be overcome. We have a quote from Uganda where a participant is saying, I haven't felt any challenge. At first, I was afraid that I would make a mistake, but I reassured myself, and I'm now okay. So with continuous counseling, I think they'll get better. It just requires the good attitude of a provider. So what are we saying, coming back to our question? What is the potential for self-injection to promote contraceptive agency? Women articulate self-injection contributes to improved ability to act on decision to use contraception through, one, enhanced privacy, and easier, more reliable access. So we need to address the issues of privacy. We need to address the issues of access. The sense of control SI offers appeals to women that already have a high degree of contraceptive agency and may help women develop self-efficacy as they learn and use the method. So those that already have the appeal to self-injections, they are the ones who feel in control. So we have a law to motivate those who are not there. And women with low contraceptive agency stand to benefit the most from SI, but may face barriers related to the degree of privacy and access to initial training. Fear remains a large challenge for all, but does not persist for most users. So, for SI to reach its full potential, programs should recognize self-injection may not seem private enough. What should we do? Maybe we need to explore ways to access, store, and dispose of units that preserve privacy. And we need to ensure access to health personnel to support side effects management when necessary. That's to make a follow-up that maintains the privacy to the clients when in case they have side effects. And also limiting SI training to healthy facilities hampers accessibility. Maybe we have focused more on training to those who are working in healthy facilities, but we need to go beyond. So expand access to SI training through pharmacies, through digital solutions, and community health workers. Also, self-care may imply lack of support to some women and contribute to fears. We need to establish peer support networks utilizing seasoned SI users, that's the experienced users, can do peer counseling, and then improve access to health personnel for refresher trainings or sport support, and educate and engage supportive partners interested in corporate use. Those are the teams that worked on this research or project. I already mentioned them at the start, and we acknowledge all the other dedicated, brilliant colleagues, partners, designers, implementers, and other key stakeholders who contributed to ICANN Malawi. And for the Malawi team, we also worked hand in hand with the Ministry of Health, Reproductive Health Directorate. Thank you.
Thank you very much for the fantastic presentation about how the self-injection can promote contraception. We continue to apologize for the online participants because now they can only hear the French version of our session, unfortunately. So we apologize. Ladies and gentlemen, now it's time for questions. May I request my presenters to come in front, please? I also remind people who are attending online that they can send their questions. Thank you. Any question, comment, concern, feel free to ask. Thank you very much.
Hello, my name is Naoko Kozuki from International Rescue Committee. I have a question for our second and third speakers. You mentioned the kind of provider perspectives or willingness to train youth around self-injection. And I'm wondering if you can speak more on insights around what is different about self-injection specifically compared to other family planning methods that's driving this kind of willingness around providers training individuals on that. So what in general versus self-injection specifically?
Did you mention to whom is you address your question? The second presenter, right? Okay, anyone who is willing to answer the question, volunteering? Okay, please.
Okay, I'll go first. For our research, providers were hesitating to offer young people the MPSC for self-injection because some of them quoted that they wanted to train them first before allowing them take it home. And some of them also, my presentation was about bias. They had this bias that the MPASC might delay return to fertility. So that's why they were hesitant to give young or married women who are nulliparous, who hadn't given birth. So that's why they weren't really willing to offer this particular method to them.
So in addition to that, generally the barriers apply to all contraceptive methods. But what we found interesting is the fact that providers felt that adolescents and youth are still not at that level where they should be able to take charge of their contraceptive decisions. And we even had a quote of one provider saying, if they want to use, let them come and just continue taking condoms, so that we increasingly have that contact with them. But I'm not comfortable providing this method to an adolescent or a youth who can basically go and just administer it to herself.
I think it was in the last presentation, but maybe even the previous presenters. What I want to confirm is that you're finding that women who are inclined to self-inject, you're saying that women who had higher agency to begin with seem to demonstrate agency to self-inject. So is there like an inherent bias in the clients who are coming forth for self-inject? I mean, are they better educated, have more contraceptive autonomy and agency? And if that is true, how does that tie up with the concerns about privacy and potential for covert use? So are you also finding that women who prefer self-inject have higher agency to begin with may also be women who prefer the attribute of privacy and may likely to be covert users? Do you have any understanding of that from your qualitative research?
Thank you for that question. the self-injection one, then already we can see the type of clients who are being motivated to use self-injection. Thank you. And we have people within within who can help with responding to that. Thank you. Within the audience.
I can also answer, though it's not from the study that I presented, but we also did a formative assessment, basically talking to the providers and clients. And one of the things that we found interesting was providers told us that they prefer offering SI to more, in fact, the word was more elite women who are more educated, because they had that perception that a more educated woman is more likely to follow the instructions of, how to self-inject themselves. They are able to have more agency than a lesser educated women. So there is that bias. We are also finding it from the lens of the provider.
I think that this idea of agency is around DMPA SC self-injection is more complex. We are realizing it in studying this, that it's more complex than we originally thought. And that in some places, women, I would say they have the agency. They realize, for example, that they want to use this method, and they know that at home, if they took stock home, they may be found out. They want to covertly use, but covert use, in some case, may be fine for them to take the units home, if they have the capacity, if they have the ability to hide it or to covertly use it at home. But covert use may also mean I will go to the health facility to be injected by the health provider, so that I can covertly use, so that nobody knows what I'm doing. And so in the literature, we need to start to unpack some of what we really mean by covert use, because I can be covertly using by actually going to the health facility to be injected, so that my community doesn't know that I'm using this. Thank you.
My question is for Susan from Victoria, and thank you for the presentation, and thank you, everyone. So when you showed the cascade, you talked about clients that were willing to take up SI, but they ended up not being training. And I want you to talk more on that. What was the reason why that gap was left? If they were interested to receive SI, and the provider decided not to train them on it, did you find out some reasons why the providers weren't doing that?
We did this as an exit interview, basically after they had already received the service. So we asked them, would you been, prior to your interaction with the provider, would you have been interested in learning more about SI? Would you have been interested to receive training? And the fact that they didn't end up taking a method is because they were not given that opportunity. In fact, as I indicated, almost half of them didn't even know that there's a method called self-inject. So there is that gap between, again, the kind of interaction they have with the provider.
Thank you very much, all. So my question is, one is around agency, because to my understanding, agencies is a relative term, especially in societies where there are conservative cultures. It differs, and also between married and unmarried kind of things. These are, very different things. So I do appreciate to understand whether those factors were considered where you are trying to, investigate around agency between the married and unmarried, between youth and that of adults. So is there any kind of variability around that? And the other question is around the government engagement, these processes, all the researchers, if I might missed it, I don't know. What is that perspective looks like from the system and the leadership side? Is there like an appetite to go for that, or is there like kind of, for instance, in my country, injectable is a leading method. So in those cases, what is the value add of like this, giving this option? As long as people are going for that, does it add value and helps? Is there a kind of analysis in terms of time and cost so that it helps the girls and the women to make like easy use of those things? And the other piece is around husband engagement. Is there any like kind of investigation to know and understand how husbands are or partners are supporting or not? Thanks so much.
Thank you. I think those questions are enlightening. I should call them enlightening. Let me start with the value added for SI. My response is yes, there's a value added. You can see so many partners we are in that. And I think a baseline was done, and talking to the women, it has been a relief to them, looking at the several barriers that women face in accessing contraceptives in the different countries that we are operating in. So a pilot was done, and after a pilot was done, it was rolled out in the countries, and then there have been studies that have looked at enablers and barriers to uptake of this method, and it has indeed added value from the perspective of women. On government engagement, my answer is also yes. There has been government engagement, policy workers, the education sector, the practice sector, the research sector. We are all working together as a team to look at the factors that might affect the scaling up of this, or the factors that might affect the utilization of the method in the perspective of the user. So the feasibility studies have helped in this, and the government is well informed. That's why I said we've been working with the Ministry of Health in this. And I think it's working for the women. If we look at the benefits, you look at the cost effectiveness, you look at the ease, the women, they're feeling in control. So it's working. In terms of male involvement or married versus unmarried women, yes, there are differences, and it depends on the context. That's why in one of the objectives, we said we looked at the contextual factors that might facilitate the use of DMPA SC in different contexts. So depending on the context where you are operating, the understanding of the context is key. And we acknowledge that male involvement has been an issue, not only in family planning, but in several aspects. And on government policy, I think that is one of the things where we are working with male awareness to say males should be involved in family planning, because we don't want to be seen like encouraging covert use. But if couples are engaged in this, they should be able to make progress in using this method. Maybe I've left some other things. Yeah, I have friends here who can help.
Yeah, to add on the male engagement, it was not part of this study, but we had done some formative assessment while we were in the first phase of the rollout. So we had some focus group discussions with men, and what we learned is that most of the women were not aware about the MPSC self-injection at all, which is expected, but also they had a lot of misconception about family planning. And part of that process was informing, sharing key information about self-injection, and most of them actually recognize that self-injection might benefit their women and themselves, because some of them, said, I know my wife is going to the facilities every 3 months, so if she doesn't have to go there that frequent, it might save time. She might care for our baby instead of going there. So they recognize the value of self-injection after being informed. But this all takes us to the point that we need to work more in engaging men in our community, because they haven't been part of this SRH process. In terms of government engagement, I think Marta has said a lot, but just to emphasize that this research that have been presented today from Malawi, they are part of the monitoring, evaluation, and learning agenda, which is part of the national introduction plan. So, the country has a structured introduction strategy, which includes also exploring, the barriers and the challenges that we face in implementing self-injection. Thank you.
Have only 1 minute left. Just a short question, please.
Yeah, I just wanted to add to Martha's lovely response to it. There's a lot of discussion about agency, and I think one thing that we're looking at in ICANN is thinking about how, yes, so it seems likely that early adopters have a high degree of agency. That's something that we're exploring, right? And but the question is, what might this method do to increase agency among people who have less of it, right? What are the opportunities there? And so that's something that we're really trying to take a look at. And we see these opportunistic moments, for example, for young women, as Martha pointed out, who may have less agency at the moment, but this particular type of method might give them the opportunity to use covertly if they need to, for example, if they feel that that's safe and reasonable for them to do so. So that's an open question and something that we're thinking about a lot, and certainly welcome much more engagement on. As Liz pointed out, it's a very complex concept.
All right, thanks. Unfortunately, the time is against us. I encourage those who have some questions that you can continue the discussion after this session, or even send the emails for further questions to our presenters. So before we conclude our session, I have two announcements. The first is that all these presentations will be available on the ICFP website in the coming weeks. And the second one is just to remind that we rely on the feedback of everybody who participated. So expect the surveys in the coming weeks. So please help us to fill the surveys. So ladies and gentlemen, a big round of applause for our speakers. We now know the opportunities, challenges, biases facing self-injection contraceptive programs, and we have evidence that it can work, and we know how we can be doing this in the coming future. So thank you very much for everybody who attended, and we apologize once again for those who are online who have been having some technological problems. So thank you very much. Thank you very much. See you again.